Okay, so I'm going to be talking about quantitative MR. If I can get my slides working, there we go. Before I start my presentation, I do want to disclose that I receive research support from Siemens and royalties for magnetic resonance fingerprinting, which I'll be talking about a little bit in this talk. So I have one other disclosure that I have to make, which is that I love quantitative MRI. I do. I think that most of the images that we're collecting in MR, they're not quantitative. So what you see here is an image of the heart. There are some pixels that are black and some are white and some are gray. And this image is a result of a number of tissue properties coming together so that we generate contrast and we can distinguish different tissues from one another. But I really don't understand why we would want to collect this more qualitative image when we have the potential to collect a quantitative map of tissue properties. So you can see here, on the right-hand side, we're actually making a measurement of T1 instead of just using T1 and other properties to make the image on the left-hand side. And I think if we really go to this dream of quantitative MR, what would we like to do? Well, we'd like to make a map of a tissue property like T1 in a number of subjects and patients. We know which ones are healthy, we know which ones are diseased, and based on that, we could maybe draw a line and say, from the measurement of this tissue property, I can tell when I put someone else in the scanner whether their heart is healthy or whether there's something going on that I should, be taking care of as a physician. This is really where we'd love to be. And the wonderful thing about MRI is that we can measure so many different tissue properties, also potentially quantitatively. And if we measure T1, T2, ADC, where we're looking at diffusion, maybe if we make enough of these measurements, we'll be able to, again, clearly distinguish the healthy subjects from patients with disease and maybe even different diseases from one another in a really objective manner. This would be amazing. So based on this goal that we have, I've done a lot of work on quantitative MRI, so magnetic resonance fingerprinting, which we'll touch upon again later. We take these highly accelerated images and through the magic of signal processing, we turn them into quantitative maps of T1 and T2, again, in the heart. So I love it. I love quantitative MRI so much. I wrote a book about it. Even in my personal life, this is my wedding, and the people who are running the wedding, they're basically, the list of authors on the fingerprinting paper. This is really my life, quantitative MRI. But what if I'm wrong, right? What if a lot of us are wrong? And translation of quantitative MRI is a fool's errand, right? A task that will almost certainly not succeed, right? This could certainly happen. If this is the case, what have we gotten ourselves into? And so just to clarify at this point, I want to really be specific about what I mean by quantitative MRI, so what we're going to take a look at today. So when I talk about quantitative MRI, I'm talking about making maps of tissue properties where we can look at the individual pixels in an image and based on those quantitative, hopefully reproducible measurements, say something about the health of a tissue. So the properties that we would like to map are relaxation times. This is T1, T2, T2 star. These are MRI properties, but they will tell us hopefully about the health of the tissue. More physiological properties, we can look at perfusion parameters. We can measure properties of diffusion, like the apparent diffusion coefficient or fractional anisotropy. Maybe more exotic types of measurements we can make are magnetization transfer, even looking at subvoxel characteristics, so the fraction of fat in a voxel or the extracellular matrix content. These are all measurements that we could potentially make with MRI, again, on a pixel-by-pixel basis, so making this map. What I'm not talking about in this talk for quantitative MRI is measuring the size of lesions or measuring volumes. We know we can do this with MR. I wouldn't consider that the same sort of quantitative mapping. I'm not going to talk about radiomics or spectroscopy. This is kind of outside the realm. I'm really talking about mapping of these fundamental properties of the tissue. And quantitative MRI has been around for a really long time, right? So I'm talking about it now. But there's papers going way back into the 80s, and I'm not going to claim to be able to talk about the history of quantitative MRI because most of this is well before my time. But I just pulled out this paper, which I really like, from 1987, which talks about making quantitative measurements of tissue properties in animals and then in patients using the nuclear magnetic resonance images, so basically MRI. So again, this is 1987. We're going to come back to this paper quite a few times. And this is a lot of the conclusion and discussion. I don't want you to read it, but I just want to point out some interesting notes, again, which we knew in 1987. Relaxation times were actually found to be pretty accurate. This is 7% accuracy in T1, 20% in T2. This is actually not so bad for 35 years ago. We know that the precision of our measurement will be better if we take a longer time to do our measurement, right? If we try to speed it up, then we're going to have less precise measurements. This is something that we know. We want to understand the accuracy of these measurements that we're making on different systems, because we'd like to be able to compare a measurement made on one system with a measurement made on another system. And we know that if we have any inaccuracies in our scanner, those could translate into errors in our relaxation measurements. So, right, all of this is from 1987. And of course, we want to think about smaller voxels so we don't have to worry about partial volume effects. And we'll talk about that in a bit as well. Okay, so what has happened now in the past 35 or so years? Well, if we just look at PubMed and search quantitative MRI, we see that back in 1987, there were maybe 40 or so papers on quantitative MR. Even in the year 2000, there was about 500 papers per year on quantitative MR, or 500 papers, sorry, total. And even now, we see that we have a ton of papers coming out in 2020, right? This is 3,000 papers on quantitative MR. And quantitative MR, maybe that could be a number of different things, so let's narrow it down specifically to T1 mapping. And here we see the same thing, right? That we had maybe not so much activity in the 80s. By the year 2000, we have about 40 papers. And now, in the year 2020, we're talking about like 500 papers. This is a lot of research that's going into quantitative tissue property mapping. So where are we? Where has all this work gotten us, right? So specifically looking at T1 mapping, it's impossible to get away from T1 and MR, so we should have been able to do something right now with it. So we measure lots of parts of the body using MR. So where do we use T1 mapping clinically? There's one place, and it's the heart, right? This is the most complicated organ to scan. It's moving, it's beating, there's respiratory motion, but this is the only place that we really regularly collect quantitative T1 maps. And in fact, we use them quite substantially in clinical assessments of the heart. So we know that they're, compared to a normal T1 map, there's some diseases which will cause an elevation in T1. There's some diseases which will cause our T1 to be reduced. And we can use these measurements to help us kind of tease apart whether the heart is healthy or not. But even in the heart, the only place that we use quantitative T1 mapping, we know that we have a fair number of challenges, right? Even here. So this really wonderful paper, which describes all the uses of T1 mapping in the heart, says that there are a number of factors which currently preclude the standardization of T1 mapping in the heart. So this is maybe very subtle, but this paper, it's a white paper from the SCMR, came out even more strongly, and it basically said that there are significant biases in our quantitative, theoretically, quote unquote, T1 measurements, and the normal values, the values for healthy subjects, will depend on the vendor, the magnet you're using, whether you have contrast on board or not, exactly the sequence you're using, the patient population. All of these different factors come in and can give you a different normal T1 value. So basically the situation we find ourselves in is that depending on where you're making your measurement, you'll have a certain normal range, and there might be elevated values or reduced values. But you have to understand what that normal range is for your particular system in order to know how to interpret those results. So luckily, radiologists and cardiologists, they're really highly tolerant of these variations, and they understand that they will look at a T1 map and maybe get some idea about what might be going on, but they're never going to make a call just based on that T1 map. They may use it as an indication that something's going wrong, but they're always going to go back to their qualitative images to really figure out, what's happening with the patient. So this isn't exactly ideal, right? This isn't where we want to be. Our dream is maybe breaking down a little bit more. Well, what about, in other organs, right, where, we don't have motion from, respiratory motion, cardiac motion. I'm sure many of you have seen this from me before. So this is, it's a really great work that was done by the ISMRM Ad Hoc Committee for Standards in Quantitative MRI. And what they did is they said, okay, there are lots of measurements that are available on different scanners and different vendors for mapping T1 in static organs. So I'm thinking, the brain for the most part, the prostate, things that don't move. If we just deploy these standard methods where there's no motion, nothing tricky going on, what do we get? And what they found is that depending on the scanner they're working on, depending on the method, they get these wild deviations from the actual true NMR-based T1 measurements, right? And this is partly a result of the fact that we're maybe trying to scan too fast, looking for too much out of these acquisitions. But clearly, if we have these deviations that are so large, we're not going to be able to make comparisons based on what should be something that's quantitative, from scanner to scanner. This is a huge blow to quantitative MRI. So I don't mean to paint only a dire picture. We do have some success stories. So this is an example of a prostate image where commonly a T2 weighted image is collected. So just to clarify, a T2 weighted image uses the T2 property to generate this grayscale. It's not a map of T2, but we're using T2 here. So I would consider this a qualitative image. But what we also need to diagnose prostate cancer is a map of the apparent diffusion coefficient. This is essential in prostate cancer diagnosis. And so we do make these maps here, and they're used every day clinically. Sticking with the prostate, we can also make maps of perfusion. It's not quite clear if we need these or not to do our prostate assessment, but we do make these maps in the prostate and in other organs as well. Another success story is looking at fat fraction, especially in the liver. So this is really nice work by Scott Reeder's group. And what we have on the top and the bottom are two different methods for measuring fat fraction. This is in a patient who was going in for obesity surgery, I believe. And you can see that before the surgery, they had really high fraction of fat in their liver. They were put on a diet. One day before the operation, they had done pretty well already in reducing their fat fraction. And then after the operation, their fat fraction decreased significantly. And we can see this, again, using these mapping techniques. So this is something that has been successful in tissue property mapping. But what's going on, with our other quantitative measurements? Why is this so hard, right? You'd think that these fundamental properties are things that we would be able to measure, especially after we've been working on it for so long. And there are a number of reasons, and again, reasons that we've known since 1987 or before. So the first problem that we have is a mismatch between the data that we collect and the model that we try to use to figure out what that tissue property measurement should be from the data. So we would call this a model mismatch. We know that some of these mismatches come from the fact that we tell our MRI system to do something, and it doesn't exactly do what we're asking it to do, which can lead to some of these errors. Again, this was well known, so going back to my favorite paper, we see that we have dependence on exactly how the sequence is played out, and if our model isn't right, we're going to have errors in our measurement. So this is completely well known. Going back to our cardiac T1 mapping, right, we see that we have this problem in cardiac T1 mapping. This is part of the issue. So what I'm showing here, this is work by Peter Kellman. So this is one healthy subject who has been scanned in order to generate a T1 map using 3 different sequences. So there's the very common Molly T1 mapping sequence. There's a Schmolly sequence, which is short Molly, it's a little bit faster. And then there's a Sasha sequence. And depending on which technique you use, you'll get a very different measurement of T1 in the same person, in the same scan block, okay? We can also take our data and fit it using different types of models, a 2-parameter model, 3-parameter model, et cetera, et cetera. This will also impact the measurement we get, okay? So this to me is already a little disturbing because we would like this to be a quantitative measurement, but clearly if we're not measuring the same thing every time, we're not really doing our job here. Okay, so we got our model mismatch, system imperfections. There are also a lot of other properties which could come in and influence the measurement of a single property. We knew this, so this was pulled out in this paper. We know that diffusion, for instance, will influence our T2 measurements. The same thing is true going back to our cardiac T1 mapping. We know that if there's fat or iron or inhomogeneities in our main magnetic fields, we'll get errors. If we don't take magnetization transfer into account, we'll get errors. Basically, everything that's not T1 is going to affect our measurement of T1. And we usually try not to take that into account because we just want to keep our model pretty simple. What else? So tissue is also way more complicated than we pretend it is as MR physicists or engineers. Again, we knew this in 1987. This paper says that tissues in the brain exhibit not mono-exponential T1 or T2, maybe bi-exponential, maybe even more features. So what's happening here? So as a physicist, I like to think of MRI as like this giant chunk of tissue with a T1 and a T2 value associated with it. And on the size scales of MRI, this is clearly not going to be the case, right? If we're talking about a voxel that's a millimeter by a millimeter, my simple physics view is completely wrong, right? Instead, we have blood vessels, we have cells. These are each going to have their own T1 and T2 values, which are going to conglomerate together. We might have exchange between these different compartments. We may have pathological tissue. Like there's all sorts of things going on that I'd prefer not to think about when I'm making my quantitative measurement because it just becomes way too complicated. And so all of these factors come together and they give us a much more muddied picture when we're scanning healthy subjects or patients. It's not quite this nice separation that we'd like to see. And in this case, if we scan somebody, we have no idea what that measurement is going to tell us, right? And this is, again, why, when we make our cardiac T1 maps, our cardiologists and radiologists, only use them as part of a larger set of information because we have this huge problem. Okay, so, there are some other issues that are happening which maybe aren't really MR's problem, but they are things that we have to consider when we're talking about making these measurements. So one is that there's just normal variation in humans, right? That not everybody might have exactly the same, T1 or T2 value for, the same part of their body. So again, sticking with cardiac T1, this is a really nice paper where measurements were made in, just a ton of people using Schmally, the short version of the cardiac T1 mapping. So what you see is this is women in gray here, these bars, and men are in these shaded bars, and these are different age categories. And so young women have a much higher T1 value in the heart than young men. And this is clearly statistically significant. These are like, 40 millisecond differences, which is pretty big here. But that difference goes away when women get a little bit older, right? So again, if you're not interpreting the value you get in the context of, the gender of the person or the age of the person, you may not know what you're looking at. They also looked at a number of other confounding factors. And even when you take away the influence of the sex of the person or their age, there's still a heart rate dependency of the T1 values that you measure. This is in this little plot up here. So that smacks to me again of a model mismatch, right? That there's something going on when the heart rate is too fast that we're not really building in properly into our model. Again, this is a little sad. And this is a paper that I love. It came out very recently and it's just amazing. So this group made measurements of cardiac T1 and T2 in a number of healthy subjects. They did a baseline measurement here. Then they asked their subjects to stop drinking water for a while, and they made another measurement. And then they allowed their subjects to drink water again. So this was over a couple of days. But you can see that the T1 value, again, is quite significantly different, T2 as well, when they asked their subjects to become more dehydrated. So you can imagine if you don't really know, did the person drink a lot of coffee? Did they just come off, a flight from San Francisco? Like, how hydrated is the person that you're measuring? That's also going to impact. I know, poor Mickey's heart is 800, I think. It's falling apart. And when you delve into the data, it turns out that not every person even reacted the same way, right? So this is the individual measurements that they made on these subjects. And for the most part, the T1 value decreased upon dehydration. But again, not for everybody, right? So this is not, again, the problem necessarily of MRI, but it's something that we have to take into account when we're trying to make our measurements. And I think one of the biggest challenges when it comes not only to the technical development but the translation itself is that physicians are really amazing at interpreting the qualitative images, right? So yes, they have to kind of put all of these different weighted images into their mind and kind of think through what these things must mean, but they've gotten really good at that. That's what they're trained to do, And so trying to convince them that maybe we should move to something different is tricky. When they're talking about qualitative images, they have the resolution they want. This is really important. They know how to interpret those different contrasts. They know how different pathologies are going to appear. And why would they want to change that if that's working, right? All the physicists and electrical engineers and biomedical engineers in the world couldn't convince them unless there's a really, really good reason to move away from the paradigm that they've been using, since the advent of MRI, right? This is going to be hard. And just, a quick aside back to those success stories that we talked about, diffusion and perfusion, like they're not so innocent either, right? So if we look at diffusion, we see that again, if there are any inconsistencies in the model or gradient errors, so imperfections in how we're doing the scan, this leads to errors in the measurement. We have also confounding factors, fat, again, T2 is clearly going to be an issue. Any changes in physiology, right? So these are going to affect our diffusion measurements. The reason that we continue to make those measurements, quantitative measurements, is because they're so valuable, right? This is one of those areas where, the physician could not make the calls that they need to without having those measurements. And so they put up with some of these issues because they know that that information is essential, right? They need it. So it's okay if it's not exactly, totally what they were looking for. The same thing is true for perfusion. I'm not going to get into that. But again, those success stories of quantitative mapping techniques maybe are suffering from some of these problems too. We're just not seeing them in the same way we are for T1 and T2. And we knew these things, right, back in 1987. So, like, why are we doing this? Why are we, working, like, chipping away with maybe a hammer that is, not necessarily going to solve maybe a problem that we don't even need to be solving? Like, why have I spent my career, trying to make this work? Maybe this isn't the right thing to do. But there's a lot of reasons that we are still persevering. We still want to try to do this. It just seems like, gosh, like the potential of MRI is just being, not really brought to fruition if we don't make these quantitative measurements. We could easily make a flow chart where we could say we've measured these different values and that means you have this disease. We could, make measurements in all different scanners all around the world and pool them together, and we'd have so much info that we could use to maybe tease apart some of these subtle differences in measurements. This could be potentially a super easy, comprehensive scan. It's so cool, we just can't let it go, I think. Okay, so now I'm going to switch gears and say why I think maybe now is the time, and this is where we could start the fistfights and the conversation afterwards. But I think, maybe now we have much better hammers. We had that hammer before, which maybe wasn't so great. We have lots of new tools that have come to our disposal, and these tools have something in common. They all take advantage of just the dramatic computing power that we have now, right? Now we can do a lot more computation a lot faster than we used to be able to. I mean, look at us back in '87, we could basically do nothing. Now, we can kind of calculate whatever we want, right? So a lot of the reasons that we really relied on simple models back in the '80s and we got stuck in that maybe in the '90s and the 2000s is because we really couldn't calculate all that quickly. And so we had to keep things simple. But now things maybe are a little bit different. So the hammer that I like to work with is magnetic resonance fingerprinting. I'm going to say here, though, that this is just one hammer, again, in this big arsenal of hammers. And I'm going to look at how fingerprinting might help solve this problem. But I think that I just want to, really push on the fact here that there's a lot of techniques which use similar ideas. And so fingerprinting might not be the answer, but I think it does have a lot of elements which can help us overcome some of the challenges that we've seen. Okay, so let's take a look at what fingerprinting actually is. And again, I'm going to stick with the heart because this is what I've been working on for the past couple of years. So this really teeny tiny graphic up here is the sequence diagram for fingerprinting in the heart. So you can see we scan in this little tiny blue window in diastole. In our pulse sequence, we play out these different flip angles in order to sensitize our signal to T1 and T2. We also play out a little inversion pulse here that helps with T1. And some T2 preparation pulses to help sensitize our signal to T2. So we want to be sensitive to both T1 and T2 at the same time. Our acquisition is done with these very highly undersampled spirals. So if we take our spiral k-space data and we convert it into an image, it looks horrible because we're so highly undersampled, right? There's just basically no information at all in our images. But if we look at all of these images over time, where they've been sensitized in different ways to the tissue properties, we'll see that this little pixel over time will have some sort of shape. And this shape is really noisy because we have these highly accelerated images, but the shape does have something to do with the tissue properties that were in that pixel, right? Again, there's a lot of noise because we didn't collect a lot of data, but we can still maybe tease apart what's going on with our signal here based on the data over time. And the way that we do that is we build a giant dictionary, right? We understand the physics of MRI, this is the block equations, and we say, based on what I did over here at my scanner, and the T1 and T2 that I could maybe expect to see in my tissue, I can give you, a reasonable subset of everything that could possibly come out of my scanner. There's nothing else really that could have happened. And then I take the signal I did measure, compare it to the signals that I could have gotten. I know the tissue properties that I put in to make my dictionary, and once I find, the best signal in my dictionary that matches, then I know the T1 and T2 that must have been in that pixel that generated that signal. So I do that for all my pixels, and I end up with these really nice T1 and T2 maps pretty quickly, but something that works, fairly nicely to get these simultaneous measurements. And so as you can see, fingerprinting depends on this computing power, right? There's a couple of places where we need to have, that computation that we didn't have 35 years ago. So the first place is in simulating the block equations. So the block equations themselves are pretty straightforward, but if we want to really do a good simulation for a lot of different combinations of tissue properties, then we need computing power. We're also generating this giant dictionary, right? If you think about all the combinations of T1 and T2 we're putting together, that's a lot of entries, right? So having a big computer helps in that case. And then finally, we have to take the signal that we measured and try to match it to that giant dictionary. That's also going to take some computation time, right? It's really like finding a needle in the haystack, which one is going to be the best. So we're reliant on being able to calculate really quickly. Okay, so now I've told you, our new tool, fingerprinting, why we didn't have it 35 years ago, because we couldn't calculate all of these things. But how is fingerprinting going to help us translate quantitative MR? So let's look again at all the problems we saw before and see if fingerprinting might be able to help. Okay, so the first thing we want to look at is this model mismatch, or system imperfections, right? And this happened in our conventional techniques because we tried to build a really simple model. We wanted to fit our data to a model to help us figure out the relaxation measurement or whatever. But again, when our signal was off because of system imperfections, this led to problems. And fingerprinting is no different, right? Fingerprinting is susceptible to all of these same imperfections. So this is work that Michael Bock did, and he found that if you didn't incorporate the actual slice profile that we get from basically imperfect RF pulses, and if you didn't look at the off resonance, then the measurements that you got for T1 were going to be pretty bad. But if you incorporate the slice profile and the off resonance into your model, all of a sudden these measurements line up really nicely, which is exactly what we'd want to have happen. We just needed to model it correctly. We've seen the same thing when we did our cardiac work. So each of these little dots here is a different pulse sequence that we could use for fingerprinting. And if we don't correct for things like, again, slice profile, inversion efficiency, the B1 fields that we're using to excite our signal, then our measurements are going to be wild. But we can just build all of that into our model, right? It's complicated. It takes some more computation power, but it's certainly doable. And this is going to clean up the measurements that we get. So I think a lot of groups have seen that, if you end up seeing that there's some system imperfection that's a problem, just model it. Basically everything that we need to worry about, just plop it into your model. So there's a couple of different ways we can do that. If we're thinking about like B1 fields, so if our excitation profile isn't exactly what we wanted it to be, we can either measure that independently and then use that in our fingerprinting model. Or if we want to get really fancy, we can just add those imperfections as an extra dimension into our dictionary. So then we're modeling T1, T2, and B1, for instance. And I think at this point, everyone says, oh my gosh, even with computation power, isn't this going to get really complicated and take a really long time? And the answer is yes, it can be very complicated. But this is where we have machine learning to the rescue. So I think Andrew is correct in saying that we have to be cautious about how we apply our AI. But in many of these cases, we're simply using machine learning in order to model known physics. That's fairly safe and straightforward. At least that's my belief personally. And so everyone seems to think that machine learning is going to be really great with fingerprinting, and I'm one of those people too. Okay, what about confounding factors, like other tissue properties that are messing up our acquisitions? So again, the bad news is that fingerprinting is sensitive to a lot of different tissue properties, and those can confound our measurements, exactly like conventional techniques. But the good news is that fingerprinting is sensitive to a lot of different tissue properties. And if we can model those exactly the same as our imperfections, then we can measure those too. So here's some nice work where it was shown that if we model the fat fraction in our tissue and we extract that, so we get rid of the fat, then we can get cleaner measurements than we would have if we had just gone ahead with our fingerprinting measurements. So not only can we make measurements, for instance, of fat fraction themselves, but that measurement, this is the measurement of T1 and T2 in water, this is in the knee, with a fat fraction measurement, this is much more accurate or close to the conventional techniques than if we leave that fat fraction in. And so here fingerprinting kind of has a leg up because it allows us to do this modeling, which gives us an additional tissue property, and also more accurate reflections of those tissue properties that we wanted to measure in the first place. And a number of groups have seen that this is the case. Here we go. So I think that this is something that now is a fairly straightforward thing that we should be doing, is modeling things like fat fraction. Diffusion also, is definitely the elephant in the room, which can mess up some of our measurements. But again, if we model this carefully, then we don't have to worry about it. And when we take all of these factors into account, we end up with measurements that are robust and repeatable. So this is an example of a fingerprinting measurement that was made in a phantom over a month. And you can see that the measurements stay pretty similar. These T2 values are a little misleading. They're very, very long and not taken into account in our dictionary. So I apologize that they're even on the slide. So, those I'm not so concerned about. But when we deploy fingerprinting at different scanners around the world, we also see that these measurements are consistent. So this is getting closer to what we want, right? This is just in a phantom, just in a water bottle. But we want our measurements to yield the same values no matter where we're deploying them. So this is good. There's also been work looking at these measurements now in vivo to see if we're getting similar measurements in different institutions in the human brain. And I think, again, these are looking fairly positive right now, that if we measure proton density, T1 or T2 using fingerprinting, then the gray matter, white matter, CSF values are fairly consistent in test-retest. Other groups have looked again at, this is a RF-corrected, FIS-based MRF, and we see the same thing. The coefficients of variation on different scanners for different parts of the brain are pretty low, actually. We're getting now to the accuracy and precision, hopefully, that we saw in 1987, when we were doing some of those slower measurements. So this is great. And the nice thing about fingerprinting is that if you want to measure a completely different property, maybe not something that's confounding, but something else that could be helpful to characterize the tissue, you can just go ahead and measure it. You just have to sensitize your signal to that property and then add it into your model. So this has been successful for T1 row mapping in addition to T1 and T2, T2 star, right? There's a lot going on. So again, wait, isn't this complicated? Like, there's all these tissue properties and all these system imperfections, and isn't this a lot of modeling? Well, again, there's a whole nother set of papers on machine learning. These are totally different ones with fingerprinting than what we saw before. And again, this is going to pave the way to making this much more rapid than if we just, even are sitting with our optimized code on a GPU. We can get now sub-second calculations of really complicated and really large dictionaries. And this is allowing us to measure a lot of tissue properties all at the same time. So this is work on chemical exchange saturation transfer fingerprinting, where we have multiple different tissue properties that we've put into our model. And as someone who's tried to work with exchange fingerprinting, where you have 6 different properties you're trying to measure at the same time, if you don't do machine learning, this is not going to happen. Your dictionaries are just so big, so unwieldy, that machine learning is clearly the way to go here. This is going to really unlock our ability to map all of these tissue properties. Okay, what about this complicated tissue, right? I'm pretending still here that a tissue is a nice homogeneous block with one T1 and one T2. Well, we can, kind of think of a way to bypass that in fingerprinting. So let's look in particular at the brain. If we assume our voxel is either made up of CSF, white matter, gray matter, or some combination of these tissues, then we can take these signal evolutions that we would expect from each of these different tissues independently, and we can build a new subdictionary, which is made up of entries, which are combinations of these different tissue properties. So again, this becomes a very large dictionary, can get really unwieldy, but this has been used successfully in a number of cases. So this is work by Maria Donjeva, where she's decomposed the fingerprinting signals into 5 different components. So this is myelin water, This is extracellular water in the white matter. This is gray matter, and then 2 components for CSF. Right? So this is pretty cool that we're now delving into subvoxel information with these maps that we saw before. And a number of groups have looked at that. I think this is a really interesting area to probe with fingerprinting. All right, how about this variation in physiology? This has nothing to do with how we're measuring it. It's just a fact of life. But again, if we have this method that we can use everywhere on every scanner and get a measurement that's going to be equivalent to any measurement we got anywhere else, then we can pool all of this massive amount of data, right? With our qualitative mapping, we can't pool really anything because those numbers don't mean anything, but with quantitative maps, they could. And so if we can get a lot of information and see how these values differ with age, with sex, with BMI, hormone levels, everything, we can really understand what is a normal variant and what could be indicative of pathology in a particular person, where this is really difficult to do right now. Okay, so maybe our variation in physiology we can work around. Finally, the fact that physicians are just amazing at interpreting these qualitative images, right? We got to try to do something to convince them, and this first starts with us. So I do want to bring up this elephant in the room for anybody who does fingerprinting. Often we would rather be fast than get to a higher resolution image. And so what we end up presenting to physicians are these maps that we think look really cool, but they just think they look really blurry because the resolution is not what they're expecting to see. And I think this is something where we have to step back and say, okay, we impress ourselves by these really fast maps of T1 and T2, but that's not actually going to be useful when it comes to translating them. We have to say it's going to take a little bit longer maybe to make these maps, but if we want the physicians to buy them, we have to give them what they want, right? So let's give them what they want, go back to the higher resolution. What about the fact that physicians, they know how their images look, right? They don't want to step away to something quantitative because that's just not what they're used to. Well, maybe, it's not ideal, but maybe we can mimic this for a little while, if my slide will go. So for instance, we can take these maps that we collect in the heart, the T1, T2, and proton density, and we can use them to mimic other contrasts. So we just calculate, from these quantitative maps, what these qualitative images would have been, just synthetic imaging. And we can do this really, really fast, and maybe even generate contrast that wouldn't really be possible using a conventional scan. And so I think in this way we can say, okay, give us the 5 seconds to make these maps. We'll give you these conventional images as well, and you can start by easing your way into the quantitative sphere without having to jump there immediately. You'll have something to still compare to your conventional images, so it makes it a little bit more comfortable. And if we can show them that we could simplify the workflow by giving them, ejection fraction measurements, which is what they want, looking at how the heart is functioning, and also T1, T2, and proton density, they might be, again, a little bit more willing to try this out just in a first step. Clearly, this is just one baby step towards where we want to go. We really want to push our physicians to think beyond what's currently possible and really completely rethink how we collect our data. And this takes time, right? This is something that, first we start with giving them the resolution, making sure they're comfortable with the images that we're collecting. But I think the next phase is to say, look what you can do with these technologies, quantitative imaging, that you can't do with other methods, right? This has to give them some information. It's like diffusion, right? Even when diffusion has some problems, they know they need diffusion because this is giving them information that nothing else can mimic. So what if we can do that with fingerprinting as well? So here's an example in epilepsy. This is from Dan Ma at Case Western Reserve University. So this is a patient with epilepsy, and so they're expecting to see something in the right temporal lobe. So they took this T1 weighted image and kind of zoomed in, and they're not seeing much of anything. Everything looks pretty much like they would expect. If you do a fingerprinting measurement, so you can look at the T1 and T2, and if you zoom into the T1 map, you see this little area of elevated T1, which really shouldn't be there. And if you go further and decompose this set of fingerprinting maps into gray matter, white matter, and CSF, you see that there's this little area of gray matter, which probably shouldn't be here, right? This is extending into the white matter, and it's this little isthmus that is causing the epilepsy in this case. And so here's this is just n equals 1 in this case, but it's an example where if you look at the conventional images, it's really hard to see anything. But if you do the fingerprinting mapping and decomposition, you can go beyond what you could see beforehand. This is work that is being done in the prostate here. This is another really great application of quantitative techniques like fingerprinting. So here the goal was to assess T1 and T2 along with conventional ADC in patients with prostate cancer. And so you can see that here is the conventional T2 weighted image with the hypointensity where the lesion is. There's also reduced ADC, which is what we would expect. And then here the fingerprinting T2 and T1 maps. And so here's the area of the lesion, and this is just the regular transition zone in the prostate. And so all of these patients, they were scanned with fingerprinting and then taken to biopsy. And basically the biopsy is the gold standard where they can say, okay, this person has cancer, you know, how bad their cancer is, what the grade is. And after that, we can do this assessment. So I apologize, it's cut off a little. This is T2 versus ADC. So if we look at these measurements, we see that in patients where this was just the normal peripheral zone, there was no cancer, all of these measurements were much higher than in patients where there was cancer discovered. And even though we weren't quite powered in order to do this, but we think it may even be possible to pull out those patients with low-grade cancer from those with high and intermediate-grade cancer. And this actually, like, I know it's kind of a boring-looking chart, but this is awesome, right? Because this is basically saying all of these people up here, you know, you took these measurements and then you gave them a biopsy. But if you had just stopped with the measurement and said, you know, these values are high, there's nothing there, then you could have spared all those people having to go in for a prostate biopsy. Like, they didn't even need to do that necessarily, you know? And I think, you know, in terms of the low-grade versus intermediate and high-grade cancer, if it's a low-grade cancer, they're not necessarily going to do anything about it at that point. So if you could say, well, we just need to watch this one, you know, see if it moves into that lower zone, again, you may be able to just bypass this biopsy altogether. This is great, actually. Like, this is exactly what we want to do with quantitative MRI. We can assess tissues just by making this measurement, which is pretty sweet. So this is work that came out really recently, and I think this is actually, again, moving in that same direction, which is pretty awesome. So fingerprinting measurements were made, and then based on these measurements, they fed them into a regression network and said whether gave a probability for there being a lesion or not based on those measurements. So exactly this flowchart style thing that we could imagine going to. So here are the fingerprinting measurements on this side, the conventional measurements over here. They made a T1 map, a T2 star map with fingerprinting, decomposed into white matter and gray matter fraction. And then down here, oh, I apologize, my mouse is a little slow. Down here, they were making a map. This is a pixel-wise map to say whether, based on the T1 or T2 or white matter, gray matter values, they suspected that area to be an MS lesion, right? And so this is really awesome. Again, you know, you give the physician the T1 map, the T2 map, maybe the conventional images. You know, you can decompose it, and then you give them the map to say, look here, this is maybe where you should look. So this is not going to replace a radiologist, but as Vikas Gulani says, this is like having the world's best resident. You know, it says, look over here, these are the patients you need to pay most attention to and the areas where you need to pay more attention to, which is really, really exciting. So I think, you know, all of this is starting to come together, and there's been just amazing advances in MR technology, and I swear Andrew and I did not gang up together on this, but I think, you know, we're moving more into this realm of, you know, anatomical imaging, this, where we can collect a ton of data just by pushing the go button. You know, again, work from Lausanne here, Matthias Stuber. This is, you imagine like starting the sequence, allowing the patient to breathe. You know, in this case, this is a cardiac scan, so their heart is beating. You're just collecting a ton of data and then, you know, taking them out and getting almost everything you need. Well, we can add to that maybe 3D free breathing fingerprinting, right? This is tissue characterization on top of it. And it feels like, you know, these two technologies, they're coming closer and closer together, where we can, you know, really think about having a super simple, comprehensive scan where, you know, it's easy for the patient, it's easy for the physician, it maybe is easy for the physician to even look at because they can be assisted by these values. And so I think my dream of, you know, having this MRF-based, free-running, maybe free-breathing, non-gated, 3D, totally automated anatomical imaging along with tissue characterization information, disease characteristics, you know, all of that could come together. This is my dream. And I feel like we're getting close. Like, we're so close to this. You know, it feels like this has got to work, right? Yeah, but then again, we've been trying to do this for 35 years, right? So I think that this is, you know, maybe I've just drank the Kool-Aid, and I hope you guys have too at this point, but I think, you know, this is where I think it's important to take a step back and say, are we going to still be encumbered by all of those problems that we had? So I'm just going to leave you with this food for thought that hopefully we can debate about later today. And when it comes to quantitative MR, are we really in a different position than we were 35 years ago? Are these tools really that helpful? And how will we be using quantitative MR in 25 years? Are we going to have that complete, comprehensive, super easy exam, or will this still be, kind of something that we add on, like T1 mapping in the heart, where we don't really just use that quantitative information? Can we really overcome all of these different challenges, or are we going to be stuck in the same spot? Should we keep doing what we've been doing, or should we all start working on low field MR? That's the question. All right, so with that, again, I'm going to say thank you so much for the invitation. It is just so fun to be here, and I'm looking forward to the talks later today in the afternoon and to the panel discussion later on. So thank you all again.
Thank you very much, Nicole, for a great talk, and again, very inspiring. So, time for questions. Questions in the audience? Please go ahead. Yes, Matthias, please.
Thank you very much, Nicole, for this great presentation. On one of your first slides in the upper left corner, this tiny, teeny sequence you were showing, right? And then later on, when you showed the correlation between the different values, T1 values, T2 values, it seemed to me all of a sudden there is a dynamic range issue. Because in your sequence, you use an inversion pre-pulse in order to increase the dynamic range, I think, of the T1. And then in this XY plot, where you showed the different T2s, there was a broad range in the middle.
Yes, we have a little echo. All of a sudden, we got an echo.
Okay, can I just
Yes.
connect?
I think it's my Zoom that was the problem.
Okay, so I
perfect.
guess my question essentially boils down to, is it heavily dependent on the dynamic range we are looking at, what we are quantifying?
In what sense? So I'm curious.
So the T2 is not performing as well as T1 does, right? Because the dynamic range is probably...
So there's a number of reasons the T2 isn't looking so great. So I'm just going to talk about the two biggest problems. So the first is that we make our fingerprinting sequences specifically. So there's a lot of talk about it's a random pulse sequence with random parameters. That couldn't be further from the truth, because we have to specially design how we play out the different MR parameters and knobs and buttons, the repetition time, the flip angle, the echo time, in order to generate signals that will look different for different T1 and T2 values. So, I think one thing that we try to do is to say in this range where we know we're going to find normal cardiac tissue or things, a little higher or a little lower, those signal evolutions have to be different, because if they're not, we won't be able to tell them apart in the pattern matching stage. And so we know that the pulse sequences that we are using, we have to give up at some point, because we can't make every single, combination of T1 and T2 look different. I'm just going to close that for now. And so, once we get to those really high T2 values that we don't expect to see, in the heart especially, or just in the body, then we know that those signal evolutions are going to start to look similar, because we're just not able to capture the differences. I think this actually in the heart hasn't really been a problem. We do see this in the prostate, where with conventional imaging approaches, we've seen the T2 can get to 200 milliseconds or so, but when we do fingerprinting, we're getting larger values that we didn't expect to be seeing, and we didn't design our pulse sequence to be able to capture really accurate differences at higher than 200 milliseconds. So that's going to cause some problems. The second issue is that unless you're using machine learning to make your dictionary, you have to choose some sort of increments for your T1 and T2 values. And what we typically do is we have smaller increments at the lower ends of the spectrum. And as those values get higher and higher, the increments get larger and larger, especially when we don't expect to see those values. But when they do pop up all of a sudden, then say your signal evolution says the T2 value should be 250 milliseconds, but your dictionary can only choose between 200 and 300 milliseconds. No matter which one it chooses, it's going to be really off. And so you're going to end up with a really noisy result. And so I think this is kind of this funny thing that happens in fingerprinting where, I can give you a map with like a perfect SNR, but it won't actually quantify anything. All I have to do is just have, 2 T1 entries and 2 T2 entries, and the whole thing will just be flat. And so this is this kind of funny decoupling of like the SNR in your maps from the measurements that you're making that you have to be careful about. And so I do think like there are a couple of dynamic range issues, and some of them are physics based and some of them are how we do our analysis, but we have to keep track of all of those things in order to make sure that we're not like forcing ourselves to get measurements. Like you're going to get an answer with fingerprinting, it's just whether it's the right answer or not. And this is why like we test and phantoms and simulations and in vivo when we can in order to make sure we're not doing that.